All right. Welcome everyone to this episode of Beyond the Headlines. My name is Kasari Govender. I'm BC's Human Rights Commissioner. My pronouns are she and her, and I am joining you today from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. I know folks are joining us from around the province, so inviting you to take a moment and think about the territory you're joining from and the folks who have cared for that land for so long. And I will when I introduce Lisa and Jonny, our guests here, I'll invite them to do their own territorial acknowledgements if they wish to do that. Our chat, I would invite you to share in the chat, but the chat actually mostly just shares with us. So excuse me. Just inviting that kind of recognition to ground us in our conversation today. I also want to acknowledge that today is Human Rights Day. It's a day set internationally to acknowledge and recognize human rights. And the theme of this year's Human Rights Day is Everyday Essentials. So for our purpose today, I was thinking about it in the context of emphasizing that human rights aren't just nice to haves. They're not just kind of the frosting on top of the cake, that they are the cake themselves. They are indeed essential for our everyday existence and our ability to live with dignity, which is so important to the conversation that we're here to speak about today. A couple of housekeeping things before we go any further. We do, as you can see pinned on your screen, and please do let us know if you have any trouble seeing this, but we have Lisa joining us right now, one of the two Lisas, who is our ASL interpreter. Thank you so much, Lisa, for being with us today. John will be switching off with Lisa throughout the time so that we have ASL interpretation throughout our event today. Closed captioning is available by clicking on the two CCs for me, it's the bottom of my screen. Changing the language, you can change the language with the arrow there as well. So you can already see that folks from our team will be in the chat posting relevant links. They'll also be there for any tech issues. So if you need to message, if you've got something going on, please message us and let us know that you can't hear or you can't see interpretation or whatever it is that's going on for you, and we'll do our best to meet those needs. That's the royal we. We have a wonderful team of folks in the background working to support us here. Webinar participants, as I said, can't communicate with each other in the chat, so you're going to be messaging to us and folks from our team will be messaging out to you. Questions can be entered in the Q&A function. So please, at the bottom of your screen, you'll see a little Q&A box. Please enter your questions there. We're going to be leaving time at the end of our conversation. We'll have some dialogue between Jonny and Lisa and I, and then we'll move over to questions. So we really do want to hear from you. Please feel free to drop those questions in as we go, as you think of them, or you can save them for then. You'll notice that we are recording the session today so we can post it on our website as an ongoing resource. And if you want to share it with folks afterwards, that would be the way to do that. As you know, we're here as part of our Beyond the Headlines series, which is a series of conversations that I've had the honor to host with experts, advocates, thinkers on a variety of human rights topics that are really important to the world around us. Today's topic, addressing the toxic drug crisis, is one that is particularly well suited, I think, for the name of this series. There's been a lot of headlines, especially recently, around the toxic drug crisis and people impacted by substance use. And those headlines are too often kind of mired in stigma, have some misinformation or disinformation behind them. And so it's really important that we get behind them as well, and that we understand, first of all, focus on the real people impacted by this crisis, and also really kind of unpack some of the assumptions that are being made and understand where the evidence actually lies. Turning to our wonderful guests that are joining us today, I want to first introduce Jonny Morris, who is the CEO of the Canadian Mental Health Association, the BC division. He's a visionary leader with over 2 decades of experience in community mental health care. He has held key roles in advocating for mental health and system transformation in suicide prevention, early intervention, and addictions programs. He's a sought-after speaker, thought leader, and tireless advocate for public policy changes at the local, provincial, and national level. He comes to this work with his own lived and living experience, with a background in research and practice in suicide prevention, combined with his experience as a counselor, professor, and facilitator. He played a crucial role in shaping the provincial portfolio around mental health and addictions. He's a true leader in every sense of the word. I've known Jonny for many years and can attest to his incredibly sharp mind that is coupled with his deep compassion. Jonny is so happy to have you here with us. Thank you and welcome. Lisa Lapointe, I should say, given that we have two Lisas. Lisa Lapointe was BC's Chief Coroner from February 2011 until her retirement in February 2024, ensuring the independent and objective investigation of all unnatural and unexpected deaths in the province during her 13-year tenure. In 2018, under Lisa's leadership, the Coroner's Service was awarded the inaugural Premier's Award for Evidence-Based Design for its analysis and timely reporting of data on illicit drug overdose deaths in the midst of a public health emergency, expertise that we're definitely going to be drawing on in our conversation today. Following her retirement, Lisa has continued to advocate for an evidence-informed response to BC's toxic drug crisis, in which 18,000 lives have been lost to the unregulated unregulated drug supply since 2016. She is regularly invited to speak with community and professional groups, both provincially and nationally, about the facts and impacts of current drug policy and legislation and the measures necessary to reduce harms and save lives. I have long respected Lisa's fearless and clear-eyed vision on the toxic drug crisis, and I am again so pleased and honored that you're willing to join us today. So welcome, Lisa. We're going to start today, before we jump into more of our conversation, we're going to start with a short video that we produced as part of our series that we call I Love My Human Rights. It's a storytelling series. The goal of this was to build empathy, to build understanding of issues through first-person storytelling. They're just short little windows of insight into somebody's lives, but I think they provide such a powerful insight that, you know, the more kind of perhaps distant conversation in some ways that we'll have today really needs to be grounded, I think, in this lived experience. Guy Facilla describes himself as a former drug user who is able to recover and build a different life for himself thanks to access to a range of services and people who care about him. Guy's story illustrates what's possible when people can access the supports they need rather than being stigmatized and punished for substance use. So we are really grateful that Guy was willing to share share his story with us. We released this video a couple of weeks ago now. As I said, we want to share it in the spirit of grounding our conversation today in a place of lived experience. The toxic drug crisis is the leading cause of death for people in the province between 19 and 59. And yet, in my view, policy solutions have either been stalled because of lack of attention or misdirected because of ill-advised responses that fail to follow the science. And at the root of both of these responses is stigma and a devaluing of human experience. We must remember, both in our conversation today, but also in the broader public policy debates, that a huge number of people in this province from all walks of life have been touched by this crisis, either as substance users themselves or loved ones of folks who have used substances and been affected by their toxicity. Their experiences need to remain at the heart of our conversation. And along those same lines, we know that folks in our audience have been touched by this as well. And I encourage you to do whatever you need to do to take care of yourself during this conversation, because it is certainly a heavy one. So with that, we will turn to Guy's story. I'll ask our team in the background to get that playing. Thank you.
I'm a former drug user who struggled for decades in the downtown east side. Everybody looks at you as just some junky loser because you're using drugs, but They don't understand the story behind people of why they're using them. My name's Guy Falicella, and I'm a former drug user who had to be brought back to life 6 times. I grew up in a middle class home. We had nice things. There was money. Everything from the outside would look good, but there were a lot of things people couldn't see: verbal abuse, physical abuse. I started using drugs at 12. I was a drug user that was trying to numb pain more than being a social user. If you don't find love and acceptance in the places that you'll need it the most, you'll seek it elsewhere. And I've never met a drug user that hasn't struggled with trauma. I was incarcerated at 14 for a year in juvenile detention. When I got out of incarceration, I was also made a ward of the court. When I got to this group home, it was really good for a while, but then they start bouncing you around from home to home. And so when you live in an unpredictable environment, that your housing can be removed anytime, you are really just in a survival mode. Out of the 6 overdoses that I've had in my life, I've never remembered overdosing. It's just pure darkness. It's not something that you feel. It's not like, oops, I did too much. It's just done. But yeah, the last overdose, the nurse described it as the longest overdose that they'd seen. I was gone for 8 minutes, that I had no oxygen levels. I just remember waking up and seeing the nurse. She was visibly emotional, and I just asked her, why are you crying? And she said, because I care about you. And I just burst into tears, man. And I just told her that I don't want to do this anymore. I don't know how to stop them. Stigma is the main reason why people don't reach out for support when they're struggling. We don't humanize people. We try to shame them instead, or we judge them for how they're living their lives. You need all the tools in the toolbox in order to really help people move forward with their lives. Structural change is needed completely in our society. Get off the drugs, your life will get better. It's no. That is a simple slogan that does not solve complex challenges. And why do they keep going back to drugs? It's because the access to other support services is unavailable, and the opportunities for people to be successful in our society are very, extremely challenging to get to. I am definitely an advocate for harm reduction, recovery, and housing. There is absolutely 100% equivalently no doubt in my mind that people all deserve access to those services. Those 3 things in combination, but also connection. I went to counseling, I went to therapy, I talked to people, I had a sponsor, I had a mentor. I had all these things now that were in my life. I had a bunch of people that cared about me. I found out in my life that it wasn't really so much as getting off the drugs. It was creating a new life where it's easier not to go back to those drugs. I have a really good life. I have a beautiful partner. I have 3 beautiful kids. And I'm so glad that my kids have never seen the old life. They'll never know that person. Today I work as a peer clinical advisor for Vancouver Coastal Health and the BC Centre on Substance Use. And I basically provide insight to harm reduction services and recovery services to really try to help people who struggled with the same circumstances that I did. A healthier, happy society, it's met with more resources. People can change when there's support available for them. The past doesn't define you. It's what you do today and forward that will.
A big thank you again to Guy for sharing his powerful story with us, and as I say, grounding this conversation. Lisa, I'm gonna turn to you for the first question. In again, kind of maybe not the grounding, but the foundation to start us off. Um, can you tell us what is the toxic drug crisis, and what are the main causes at this point of the crisis and people's deaths at this point? Can you kind of lay the foundations for us here?
Thanks, Kasari. And I just want to say I'm so happy to be here. It's a pleasure to be here. And I'm actually at your offices, the unceded territories of the Musqueam, Tsleil-Waututh, and Squamish nations, although I reside in the territories of the Saanich nations on Vancouver Island. And I'm really pleased to be part of this conversation. I'm so happy that you're presenting this topic today. The toxic drug crisis is a crisis that is underpinned by drug policy and drug legislation and some of the things that Guy talked about, lack of access to supports, mental health supports, physical health supports, lack of connection. But the way it came to fruition in our province was the arrival of fentanyl. People have used drugs in our province and elsewhere for many, many years. And while no illicit drugs can be considered safe, they were relatively manageable until 2012 was the first time we saw illicit fentanyl, and that is fentanyl that is not prescribed entered the illicit drug market, and the incidence of fentanyl poisonings grew from there. At the highest peak, I think we had about 87% of the deaths in the province were related to fentanyl. So it is absolutely a fentanyl crisis, but it is due to the fact that people who are reliant on substances have to access them from the illicit market. It's, of course, unregulated, it's chaotic, it's managed by, for the most part, organized crime. And so we've seen more than 17,000 deaths in our province alone, and we continue to see 5 people dying every day.
Yeah, it's mind-boggling. One of the things that you spoke about as we were preparing for this conversation, you said something along the lines of, it's not the toxic drugs that have gotten worse over time, it's the housing crisis. Can you walk us through what the connection is? There something that Guy spoke to as well?
Yeah, so one of the things that we have seen portrayed publicly is that we have a community safety crisis, and it's related to toxic drugs and it's related to drug users, and people are using drugs on the street, and we're all inherently less safe. It's not true. People who use drugs are, for the most part, with some very, very minor exceptions, are good people. They're not out to hurt anybody. They themselves are often hurt, but they're not a risk. They're not a danger. But we see more people using drugs on the street because we have a housing crisis, and more people are living unhoused. And it gives the public the perception that, everything we've done to address the toxic drug crisis hasn't been useful. The province has done many, many good things to address the toxic drug crisis, but not enough of anything. And certainly some significant measures that could be taken haven't been taken. But we know that people who use drugs, and as Guy said in his little video, it's often as a result of trauma. It's a result of acquired brain injuries, people who are trying to cope with traumatic events that have happened to them. And particularly if you're living unhoused or with an untreated physical or mental health condition, drugs are a way to ease your pain. And that's what we see oftentimes.
Yeah, thank you for that. It's a good lead in to Jonny, my question to you, which is around what's, in your view, kind of what's the problem we're trying to solve here? What's really at the heart of it?
Thanks, Kasari, for your question. It's an honor to be here with you as Commissioner, and of course, Lisa, given her former role, and grateful to be joining you today from unceded ancestral Lekwungen speaking lands, particularly Esquimalt and Songhees. And thank you for holding space for an ongoing and really, really important dialogue about these issues. To respond to your question, I've got a few points because I think there are multiple problems that are being integrated into one mega problem. And sometimes the solutions that are being put forward to this massing problem aren't fit for purpose, or some of the problems we are trying to solve are obscured or hidden. I think of some comments recently made by Dr. Alex Corderella. He's the CEO for the Canadian Centre on Substance Use. And he framed it very powerfully, and I've learned a lot from him over the past while, I really do believe, and I think Lisa and Guy's comments underscore this, that part of this problem that we're trying to solve is an unparalleled public health emergency and crisis, imbued by tremendous amounts of systemic stigma, and also dehumanization as well. And it's unparalleled. And as Lisa was saying, there is a critical opportunity for us to marshal more of a sophisticated and ongoing and enduring response to a crisis that currently takes 5 lives every day here in British Columbia. And I think it's a point that it really needs to be underscored. We really are talking about a poisoning crisis. Guy said this, Lisa said this, we've heard this time and time again. People are dying from contaminated drugs that they may or may not have ever intended to take. Some doses are safe. Some doses are 100 times more powerful and ultimately lethal. And that complexity really does require policy action, but also services and care and humanization. I think there are other parts of this problem too, though, with treatment services. And, we're noticing already in the Mental Health Act, I know we'll get to in this conversation, there's a growing number of people already being detained under the Mental Health Act. Estimates are about 20% of folks with a primary diagnosis of substance use disorder. And given the current policy direction in British Columbia, we anticipate those numbers increasing. But meanwhile, and we heard this, Guy said this so eloquently, young people, adults and older adults are waiting months, days, months, weeks for voluntary services. All those services are inaccessible for a whole bunch of reasons we can get into in this conversation. Your recent report really framed up the impacts of brain injury and the complexity that comes with that, and are our systems fit for purpose for that complexity? Arguably not. And that unrecognized epidemic of brain injury is taking its toll in lots of ways, most importantly on the people themselves and loved ones and communities around them. And I think stigma is key. Like BC, actually, recent statistics have shown that rates of stigma here in British Columbia are some of the highest in the country. And that's coupled, actually, interestingly, with BC having some of the highest rates of unmet need when it comes to mental health and substance use services, notwithstanding the significant efforts that have been put into place. But the last thing, I think the problem that we are trying to solve is how do we resolve this very mixed narrative or smushing of problems together? And in my 25 years, I haven't seen such a strong conflation between public drug use, violence, disorder, homelessness, stigma, all kind of being wrapped up into one. And so policy options that are coming forward are really perhaps not responding to the complexity of all of those problems. And so getting clear on the fact that we do have a significant and catastrophic level of loss of life every day and injury in this province. Getting clear-eyed and focused on that, I think, really behooves us all to take action. Kasari.
I think one of the things that there's so much in what you just said, but one of the things that you said that is sticking with me is around the connection between stigma and that interesting fact that you said of highest level of stigma coupled with lowest services. It's one of the things, and thank you to Liz, who's just dropped our position statement into the chat. We released this about a month ago, and one of the really big pieces of pushback there was stigma can be a good thing. Stigma says that this should end, and therefore it will end. Drug use will end because we say it's bad. I think we're all in agreement here that that's not an effective solution, but I think what you're pointing to and what we point to in our statement is further than that. It's not an effective solution, and it's part of the problem. Is there anything you wanted to add on that, Jonny?
Well, I think bluntly put, stigma kills. I think stigma leads to silence. It means people are not as willing to raise their hand early to ask for help. Stigma means when you first knock on the door for care, you can sometimes get a really poor response from the system that's designed to be providing you care. Stigma means you're shunned and silenced, ostracized, othered, separated out. All of those things are not great for mental health, right? And, you think about stigma when it comes to people being able to talk about how they're doing and rates of suicide, particularly amongst higher risk groups. Stigma really is something that needs to get interrogated because I think, left to its own devices, stigma will have not the intended consequences that proponents of stigma might want. I think it actually will yield more catastrophic loss for folks.
Yeah.
And I wonder if it's really about safety and having conditions where people feel okay reaching out for help and care in ways that are truly trauma-informed and responsive.
Following up on that, Lisa, in your role as Chief Coroner, you once called, or maybe it was just after you left actually, but you once called the approach to substance dependence through criminalization and punishment, that sort of line of response, you called it spectacularly unsuccessful, which I thought was such a useful and definitive phrase. In your view, why can't we police our way out of this crisis?
Yeah. Thanks, Kasari. And it's a great question jumping off what Jonny was talking about in terms of stigma. And for so many years, the response to substance use has been punitive. So we've shamed people and we've marginalized people with the expectation that if we do that, we will sort of shame them into wellness, which of course we all know is illogical and makes no sense. And if you ask most people, what do you have against people using drugs? They would say, well, it's bad for their health. It's bad for them. So it's a health issue. But for decades, the legislative response has not been a health response. It's been a law enforcement response. So the funding and the resourcing to respond has gone to law enforcement. It's gone to courts. It's gone to jails, where the support that would really help, the medical support, the mental health support, the connection, has been really left stranded. And we have no evidence, and trust me, I've looked, there is no evidence to suggest that increasing enforcement results in positive outcomes for people who use drugs. If that was the case, the millions and millions of dollars that have been invested in policing over the last several decades, there would be no problem. But of course, it's in many ways made it so much worse, because harming people who are already experiencing some challenges, mental health challenges, physical health challenges with drug use, has just made the crisis so much worse. And we've, as I say, orphaned the services, or really not funded to any meaningful degree the services that would make a difference. Sorry, go ahead.
No, go ahead. I was just going to ask you to elaborate on that. Like, what are the services that work? What are the sort of top policy responses that you want to see?
So stigma has, as Jonny mentioned, stigma means that people don't ask for help. So if I'm a teenager and I start using drugs and I do feel like, oh, maybe this is getting out of hand, I'm not going to tell my parents because all sorts of things can happen to me. Now we've got involuntary care layered on top of that. So people don't come forward because if they share with their family, they share with their employer, they share with their coworkers. Now they're put on leave. They're shunned in the workplace. Nobody wants to talk about them. So it's really had such an unintended impact, as Jonny said. And then what we haven't seen is the investments for evidence-informed treatment. So what we have in our province now, in many cases, are treatments that we think are good, that we suspect, that we hope will do the right thing. But in our province, we haven't got regulated standards for treatment for substance users. If prescribing, yes, the doctors have a very rigid rules for what they can prescribe to who and when. But in terms of residential treatment and all of these private treatments, not for profit treatments, there's no standard for treatment. More importantly, there's no requirement for reporting outcomes. So when we've seen all these investments in beds, although not nearly as many as we need, we don't know how effective that is. We know, we heard from Guy, he overdosed, I think he said 5 times or 6 times. Many people relapse when they're using substances, and the treatments that they need are not always evidence informed, and they're not available. there are lineups at every door in the treatment and recovery world. And it may be that for some people, abstinence is not the goal. And we need to, I think we need to shy away from it's always going to be abstinence. Some people can be maintained for many years with a safe level of drug, keeping in mind that any drug, prescriptions, alcohol, whatever you want to use, if used to a degree, will be unsafe. But somehow this idea that abstinence or nothing is really not an approach. We need to give this back to the medical professionals. We need to stop making the police in charge of how we respond to this health crisis, and we need to start listening to the health professionals who are telling us loud and clear what needs to happen, and for some reason are just being ignored. People like Jonny, he's not ignored, but the people like Jonny who have evidence-informed initiatives that, if properly funded, properly resourced, and initiated to a degree that more people could access them, would make a huge difference.
Yeah.
That's not happening.
My next question was for Jonny, but we've actually just got a question from the audience that's really directly relevant to what you were just saying, Lisa. So I just want to slip it in here. And you've been asked, I wonder if she might be able to provide specific ways that someone could go about demanding this information and mandating oversight and reporting. Who does this fall under? Would this be at the health authority level or beyond? If the chief coroner can't move this forward, is there any hope?
Well, it's a good question because I had no success getting that information. One of the questions I used to have, and Jonny will probably have more insight into this than me. One of the questions I used to have is, when a bed is funded, what does that mean in terms of people? What does that mean in terms of addressing this crisis, addressing the needs of individuals? How many people will be able to access that bed? What is the definition of success? What does that look like a year down the road? That information is not collected provincially. Some organizations may collect parts of it and report parts of it, but it's not reported provincially either. Certainly the private for-profit residential treatment centers, they won't share that. And I can tell you, I recently had a conversation with a family who lost their child. He had been into residential recovery a number of times, and at the last admitting interview, they were told that he had a 92% chance of relapse, and yet they were charging $30,000 a month for that family to have their loved one treated. We call that treatment. He ended up dying in his car on his lunch break. He was employed, and that's not an uncommon history. So I have no idea why the province isn't collecting that data. I think it's vitally important. And this is not the time to get into this issue, but it's interesting that we have no data on the value of law enforcement as a response. We have very little data on the value of, some treatment services as a response. We have really good data on prescribed alternatives as a response, and that's the alternative that government is not supporting. So that's a different part of this conversation, I think.
Well, actually, that was going to be my question to Jonny. So maybe pose it to Jonny, but bring it back to you, Lisa, if you have anything to add. Which was, as I understand it, less than 2% of people who use substances have access to prescription-based alternatives. Jonny, can you tell us a little bit more about what we've just heard some of this from Lisa, but if you have anything to add in terms of what are prescription-based alternatives, what does that actually mean, and why is access so limited?
Well, maybe if I may, Kasari, take up Lisa's generous invitation there on this kind of question of effective treatment writ large. Really, it's a continuum, right? And I think Guy said this over many times, like, for the complexity of this health challenge, like we really are talking about complex, enduring health conditions, illnesses. We really need to deploy, a full continuum and range of responses, much like we do with parity for complex physical health conditions too, right? Nothing is spared. And it's a false equivalency to say cancer is just like opioid use disorder. But there are some thinking there around the ways we marshal incredible resources for complex physical health conditions, and arguably deploying that full continuum is absolutely required here, given the complexity we're facing and the catastrophic loss of life. In our view at CMHA, effective treatment really, and we've written about this for years, prior to the public health emergency being called, about mental illness. We really do need to think about the whole person and their whole circumstance. We need to make sure stable housing, Lisa made this point very eloquently, an absence of housing, really does cause bad mental health for folks, right? Trauma therapy, peer support, cultural connections, access to publicly funded counseling. Arguably here in BC, we're the closest we've been to accessing publicly funded counseling and supports. There have been some real inroads there. And government has, on the record, invested significantly over the past number of years to respond to this crisis and to respond to mental ill health as well. Arguably, there's much more that we can do on the mental ill health side. But to Lisa's comment, we oversee and administer, about 307 treatment and recovery beds of different levels of intensity. And we have really heeded, because we listened to Lisa's call when she was the chief coroner, around in the absence of provincial regulation, let's make sure through contract that we're driving for quality here. We really want to see that folks who are being funded to provide publicly funded treatment care in a residential setting are not forcing, coming off OAT and those kinds of things. We're not government, we are an administrator, but we endeavor to, through contractual arrangements, make sure that the humans are not being kicked out early or left to their own devices, that there's good treatment planning. And we've got a good sense of wait times, and we do feed that data up to our funder, which is the provincial government. In many ways, that's just a small slice of the data picture, but it's hopefully encouraging government to demonstrate the public accountability we see with reporting on other illnesses and other responses and treatments here in British Columbia in a good way, because it does build trust and transparency in a system that needs those things. But when it comes to prescribed alternatives, I'm not an expert in prescribed alternatives, but what I would say is I wholeheartedly agree with Lisa's comments around the care and the guidance and the practice that's around that medical intervention for what's called prescribed alternatives. And arguably, when I hear 2% of folks who could qualify for that are accessing it, to me, we haven't met the threshold, right, of an intervention that is demonstrating efficacy in keeping people alive and safe. And arguably, there's more that can be done to mitigate the concerns and the challenges that have been associated with prescribed alternatives. So I would say there are pockets and strong momentum in places, but to Lisa's point, we have not applied enough. We're taking our foot off the gas, is what I'm trying to say. And I think in this current economic climate, where resources are getting more restricted and priorities are shifting, I worry about the danger of kind of just pulling the parachute and saying, well, we've done enough now, because I think we're not out of the woods when it comes to this public health emergency that we're still grappling with. Does that answer your question, Kasari?
Yes, thank you. And we most definitely aren't out of the woods. In fact, there's been these recent developments, which I want to turn to now. We've touched a little bit on involuntary care. It's been an eventful couple of weeks on this front. We saw the end of arguments in the constitutional challenge to aspects of the Mental Health Act. We've seen a couple of potentially important steps from the government, a new piece of legislation or revision to the Mental Health Act introduced to a bill and passed quickly. We saw a memo from the special advisor to the premier on these issues, focused on youth and involuntary care. I don't think we have the time here to kind of get into the weeds of thinking through those issues, but one of the big takeaways for me, certainly of the government actions of the last couple of weeks, has been this continual growth, maybe is a way to say it, in emphasis on involuntary care as the solution. If we put put people into hospitals and kind of lock them there. That will be what solves it. And I can, I think all of us, of course, have a great deal of compassion for the parents who have lost children, as Lisa described, and the desperation that they would inevitably feel in trying to access services. I worry that this is going to give them a false sense of hope on something that could be very deeply problematic. And I worry about the lack of evidence for supporting involuntary care as actually resulting in, in real change. Jonny, what's your position on involuntary care? If you can kind of encapsulate it. Again, I know we've had lots of conversations on this, and we could take up the whole time with this, but if you can kind of summarize what your position is, I think that would be helpful.
Yeah, I might just start with something that's come up recently, just given the Mental Health Act's been thrown into the media, and it dawned on me, inspired by actually an expert in the UK, that really, if there was to be any amendment, it would be to call that act that was currently debated in the House, the Involuntary Treatment Act. Like, the fact it's called the Mental Health Act is a bit of a misnomer in my view, because really it is an act that, since its inception in the 60s, has governed the detention and the apprehension of people with a mental disorder. And of course, it's hit the news more recently because it's subject to court challenges, and also it's being interpreted through a lens of how does that act get used for the involuntary treatment of people with a substance use disorder. And maybe for another conversation, I think about what becomes possible if we had true mental health legislation in this province that actually did the things that Lisa just said. If we had laws that, compelled government to report on data, or compelled wait time minimums, or practice standards and quality and patient safety, that would be true. That would be true mental health legislation. So, my hope in my career, I hope we see true mental health legislation in BC, because really that act is solely focused with the detention and the treatment of people here in BC. So that's one part I wanted to start on. I mean, you can probably infer from that, like CMHA BC, we have a nuanced but an evidence-based position on involuntary treatment. I think often when we get into these conversations, not with you, Kasari, per se, but any question or concern raised about this kind of sets up this very polarizing binary very, very quickly. And it's a bit of a trap that I've learned from colleagues at Health Justice and elsewhere, that maybe we can avoid the trap. We at CMHA BC have long held the view that involuntary treatment for mental illnesses, so if someone's experiencing psychosis or is very, very suicidal, as a last resort, when that person faces imminent danger, involuntary treatment, like holding on to that person and treating them, can be necessary. So we've never held the view that we're against involuntary treatment, but where things get more nuanced is the reasons we hold that view is there is meant to be more safeguarding and care. We have a ways to go in BC around that. But to your earlier comments, Kasari, about evidence, and Lisa's echoed this too, we do have significant questions around the evidence base, the safeguarding, the practice guidance, the clarity of direction and policy, the mitigation of unintended consequences when it comes to the involuntary treatment of a substance use disorder alone, on its own. And I think there are often wars of evidence. My evidence is better than your evidence. I don't think there is a clear, strong consensus that this is the right thing to do. We do need to find life-saving measures. We do need to find interventions. We do need to engage with people to make sure that they're not hurt by policy interventions around this. But that's where we have significant questions, and we haven't seen adequacy in safeguarding protections or evidence when it comes to involuntary treatment of people with a primary diagnosis of a substance use disorder. But the reality, Kasari, and I'll pause to see if Lisa has anything to add here. In British Columbia, I think there's often this sense we don't do enough involuntary treatment in British Columbia. 20,000 people in British Columbia are detained 30,000 times each year. And those numbers are going up. And as I referenced earlier, there's a significant portion of humans in those statistics that are currently being detained under the Mental Health Act in British Columbia to be treated forcibly. I do think there's huge opportunity for the public in British Columbia to better understand that what's called the Mental Health Act has tremendous powers, extraordinary powers in and around intervening on your body and treating you forcibly. That's really important to understand because what we do know, as Lisa said, is if I'm a young person and I'm using substances and it's getting a bit out of hand, and I know if I go to the hospital, I might be held or treated against my will, that might get in the way of me asking for help. Or if I have that experience, I might never come back to the mental health system ever again in my life. So that's our nuanced view on that big question you asked, Kasari. What's our position on involuntary treatment?
Thank you, Jonny. Lisa, we've spoken in the past about the impact in particular of involuntary care on young people. The memo, of course, that just came down from the special advisor to the premier is focused on young people and involuntary care for young people. And apologies, I think we're being spotlighted in different ways here, at least on my end, trying to keep up with it. Lisa, can you speak to the evidence supporting or undermining this involuntary care, particularly in the context of for youth?
I think Jonny referenced this, and the special advisor admitted this in the initial rollout of the documents, sort of moving government towards greater involuntary care for treatment of substance use. There is not good evidence to suggest that involuntary care is of value in helping people move away from substance dependency. One of the paradoxes of this crisis is that what people's instinct tells them will work, in fact, doesn't work. And so it really points to the value of evidence and why we need to look to the experts and the evidence as opposed to sort of the populist view. So people think that, well, if drugs are hurting people, we'll just ban them, and that will take care of the problem. Well, as we talked about earlier, we've seen decades of that, and that has not been successful. It's led us to the crisis where we are today, where the drug supply has gotten more toxic. It is made more easily from precursors that are available through. We have means of making drugs now that weren't available 30 or 40 years ago. So the supply is greater than ever. The way to transport them is easier than ever. So that hasn't been effective. So then, the flavor of the day now is, well, we'll just take all these people that are suffering and we'll treat them because they don't know what's good for them. If they were in their right mind, they would know what's good for them, but they don't. So we're going to do that for them. It's so dehumanizing and so disrespectful because people who use drugs, of course, they have opinions and they have thoughts and they have ideas. They're human beings, and they should be consulted and they should be respected. There has always been, as Jonny mentioned, the Mental Health Act has always allowed law enforcement to arrest people at risk of imminent harm to themselves or others. Then they would be assessed, and if the risk was deemed unmanageable or too great, then they would be admitted for treatment. But what seems to be the direction moving now is that people who are heavily dependent on substances, the assumption is that they're not capable of making decisions, therefore we'll take away their freedoms. I mean, you talked about that in your report. The challenge on so many levels, Jonny mentioned them, a huge mistrust then afterwards for approaching any kind of support or treatment because my rights may be taken away from me. The fact that it is not effective, and is the treatment going to address some of the root causes or issues that fed the substance use challenges in the first place? So living unhoused or having suffered the effects of trauma, physical assaults in the past, sexual assaults in the past, brain injuries in the past, all of these things that people sometimes try to manage with substance use. How complex is the involuntary care going to be? And in a province, and I hate to always be slamming the government because I always seem to be doing that, but in a province that has not been able to stand up adequate, evidence-informed, voluntary care for the thousands of people who want it publicly available, because there certainly are those privately funded, although arguably aren't even enough of those. Why do we now just skip to involuntary care? And frankly, there's a part of me that wonders if it's just a distraction. Look public, look what we're doing. We're going to get rid of this problem. And sadly, the problem, and I say that in parentheses, is the most vulnerable people in our society who we see living unhoused. And rather than mount the appropriate woke, which in my mind is a really good word, compassionate response, immediately addressing housing needs, poverty, poverty challenges, meals, medication, healthcare providers. Those are essentials that we need to provide right away. Instead, the government has pivoted to involuntary care, hugely expensive. I can tell you that secure custody is hugely expensive. Is that going to be at the cost of voluntary care? And given that the evidence really doesn't support involuntary care, it's really disturbing. And I'm going to get on the bandwagon yet again, because I always do, for safer alternatives, pharmaceutical alternatives, keep people alive. And so that people aren't continually going back to this poison well and acquiring brain injuries and catastrophic health events and dying because they can now be stabilized. And it doesn't have to be government funded. It could be user pay model. They can now be stabilized on safer substances. As I said, no substance is safe. And that the evidence has demonstrated in the pilots where that happened across the country, federal government funded 10 pilots across the country. Evidence was really, really positive from those pilots. That's not the political direction anymore. So we're moving in a direction that isn't evidence informed.
Yeah, you've kind of taken my next question already and answered it, because that's what I was, one of the things that I find so frustrating, and I share, Jonny, I share your position, and that involuntary care is a last resort. It's not that involuntary care can never be appropriate in a mental health context. It's that involuntary care on substance use in particular is the last resort, requires the kinds of protections, procedural protections, and needs to be proven, as you've said, Lisa, to actually be effective in the circumstances in which it's being used, and in the context of substance use, the evidence is really problematic. And I was reassured to some degree from the special advisor's memo that it says involuntary care should be a last resort. Community-based or voluntary services should be used first, but it's hard to see the meaning in that when if we're not investing in those services, if it's not available. And one of the areas that I worry about, that concerns me, there's so many from what's happened, particularly in the last week, though, is that, and I mentioned this at the beginning, that there's a lot of mis and disinformation around these issues. And the government's response to where there should be voluntary care is, look at all these beds we have, look at all these services. The implication being that there is a significant amount of service out there. I understand that the reality on the ground is quite different, and that that people are desperate for services that they're not getting. And that reassurance that this is a last resort is less meaningful if we don't actually have those services available to people on the ground. Anything either of you want to add on that side?
Yeah, it's a very powerful observation, and I would say we've monitored investment and implementation of not only substance use services but mental health and substance use services for a long time, and we've tried to keep an eye on federal funding, because that's a big part of the ingredient here is transfers from government, that the federal government, that are very specific to mental health and substance use care. And I would say there has been I mean, I'm on public record stating this, there has been significant investment. Some of it's sustained, some of it one time. But what I would say is to your question is, and we see this in the advocacy we do, there might be services, but the criteria to get into some of those services are so high that you can't access them. Some of the services geographically are inaccessible. So we do have what I've often called a bit of a postcode, well, actually a lot of a postcode lottery. When it comes to care, people have to travel out of area to get to, more specialized centers in Vancouver or urban centers. So that's disparate. We have barriers when it comes to culturally responsive or culturally safer care. There've been investments there, but care that is culturally safer and responsive to the diversity of human beings that lives across what's now known as BC, I think is an important consideration. And so there is this kind of critical conundrum around alignment and access and flow. And we don't have a tremendous amount. I was just talking with someone this morning. When we think about the almost $40 billion health budget in British Columbia, the allocation of that budget for preventive or early interventive services does not compare to the more downstream, very, very expensive interventions like the ones Lisa was just describing as well. So I would say there absolutely has been change and shift. But there is such a critical moral imperative to make sure that anyone in British Columbia can ask once for help when they're ready and get that help fast. Like, how do we create a world in British Columbia where you can ask once and get help fast, not ask 33 times and get ignored or have the door slam in your face? And I'm curious because I think there've been some laudable steps around, Access Central, which is a government's approach to, a 1-800 number where you get connected into, addiction medicine quickly and detox. That is a laudable piece if people can work together, given we're in this very resource constrained environment. There's been a lot of talk about road to recovery as well. Really trying to get people to the right place at the right time. But I do believe the proof will be in the pudding. Like, can these complex systems in a current economic climate where there's actually reductions in funding, there isn't money, how do we realize an Access Central vision? Because, if one knocks on that door and doesn't get the help that they need, they likely won't return. So I think we're a ways there. There are services, but I do think there are very, very real barriers to care. And we have a system that is still very acutely orientated to downstream acute crisis response rather than how do we prevent people from becoming ill in the first place. So that would be my view, Kasari.
Thank you for that, Jonny. Lisa, did you want to add anything to that?
You see me nodding along. It's really interesting in this crisis. There is no national or provincial strategy for prevention of substance use, and that's a really big issue. But actually taking the time or looking at the research and acknowledging the what really leads people to use substances. I mean, Guy talked about it, and it's really not a mystery. Oftentimes it's pain. People are responding to pain, and it may be not something that you or I would consider pain, but for that individual, it's personal. It is something that they are experiencing, and drugs are a way of coping with that. And we don't have good strategies for that. We don't have in the high school curriculums, in the elementary school curriculums, in the middle school curriculums. This should be in there. Children should be learning about drugs and the challenges and the risks, not in one of those scared straight kind of ways, because those weren't effective, but in a really informed, calm, educated, you will likely be exposed to drugs. Here's what drugs can do to you, giving people information to make informed choices. We don't have anything like that. So that upstream, like that Jonny's talking about. And then, family physicians should all have at their disposal tools that if their patient presents with substance use or mental health use, I mean, this is a pipe dream, but these things should be taught as part of the curriculum in medical school. Substance use is, I think for so long, it's been seen as this kind of rare non-medical challenge. It's been the challenge of criminalizing substance use is that it's really been viewed as a law enforcement issue. The investment hasn't been made into the health responses that would, address the problems really early. And that's where we need to make some, our governments need to embrace substance use as a health issue, fund the physicians. I can tell you, I've talked to, I don't know how many physicians, and Jonny probably has too, who are so frustrated that they can't treat their patients in a way that they know would be effective for their patients. They're constrained by policies and practices and the drugs that they can dispense, they can prescribe. And of course, now with these new rules coming in effect around people the few people who are on a safer supply program have to be witnessed, we're going to see that program really decline in terms of participation, because people just won't do that. It's making it so inconvenient for people. They won't be accessing the pharmacy to get their substance that they need. And there's a lot of stigma and bias associated with that as well. If you're in a small community and you go to your local pharmacy, and now everybody knows, and there's still so much shame around substance use. So it's interesting to me that our government, for the provincial government, for a number of years had a really enthusiastic anti-stigma campaign. Mm-hmm. And yet I have to say, it's one of the biggest stigmatizers. We saw the response our province mounted to COVID. We saw them stand up in every corner of our province vaccination centers, and everybody got notices and everybody got reminders for your second and for your third. We have nothing like that in terms of the toxic drug crisis. And we are still having 5 people die every day, everywhere in the province. And although there's this real stereotype that people who are dying are unhoused and they live only in, Pandora Street in Victoria or the downtown east side of Vancouver, I can tell you that most of those people who die, you never see them. They're dying at home in the suburbs, in their own homes or in their parents' homes, or, in their condos or apartments. So in some ways, it's a really hidden crisis as well. People see numbers, but they don't understand the reality of how massive this crisis is in our province. Toxic drugs are drug toxicity is the leading cause of death in our province for those 19 to 59, and has been for a number of years now. And the response has in no way been commensurate with the scale of this crisis.
Yeah. Oh, Kasari, I was just gonna, if I may.
Yeah, please.
I think Lisa's emphasis there is just it's so important, right? Because I worry about, the post-COVID impacts on the health system, a real desensitization to loss of life. The numbers have desensitized it, and Lisa's added such color there. I read a recent article in the Globe and Mail around how people are noting how the construction industry is hollowing out. Like they've lost so many professionals in the construction industry due to this phenomenon of dying due to a contaminated drug supply, that the people aren't there to build homes and construct things because they've had such a disproportionate, it's just one population, knowing that this loss of life has profound disproportionate impacts on First Nations, Inuit, Métis peoples as well. But I just wanted to underscore that, right? And have all of us respond to that moral imperative question of if this were any other health condition, would we tolerate and accept lackluster responses? There was another thought that kind of popped into my mind, and then I'll hand it back to you, Kasari, is you've referenced a few times in this conversation, like the shift in government direction, amendments to mental health acts, guidance coming out. What I think, given that's the shift and that's the direction, it is very much upon the province to be as clear as possible as to what all of this means, because it's a tremendous amount of change that's come about in about 6 months, and then very concentratedly in the past 2 weeks in a very, very overstrained health system, and also in the mental health and substance use system, a system that at the best of times can feel chaotic and unpredictable, notwithstanding the valiant efforts of very skilled professionals who operate in those contexts of care. And I think for the healthcare providers out there who are asking for clarity, that's very, very important. Like, it's one thing to shift policy and direction, but it's another thing to make sure every single physician in an ER in this province knows exactly what they can and cannot do under this seismic shift in policy and guidance. That to me is critical, because if that doesn't happen, the unintended consequences, I think, are quite significant. So I just wanted to make that point too, Kasari.
Thank you, Jonny. I was going to end our more formal part of this conversation and talking about compassion. When we released our statement, we had two, if I can roughly group it as two big pushbacks on releasing this statement, the position statement on toxic drugs, and pushing for safer supply and a harm reduction model. And one of those was, stigma is a good thing, and we talked about that piece already. If we just ban these drugs, if we just tell them no, if we just build stigma, it's going to solve the problem. We've already grappled with that. One of the other ones, though, was a misunderstanding, I think, that what we were pushing for was a preservation of the status quo. Just don't do anything. Of course, that's not, and we've talked a lot about the actions that we need to take. But in that realm of pushback, there was a lot of accusations of you have a lack of compassion because you don't want to take action for so many people dying. And it felt like a bit of everybody trying to out compassion each other on that side of the conversation. My question for you originally was going to be, how does compassion, how does centering the voices of those most impacted show up in your work? And I think for both of you, you've answered that in so many beautiful ways already in this conversation. So I will put that out and see if there's anything you want to add. But as we've been talking here, we got an interesting question that I think might help focus this a little bit more, which this is from somebody who identifies as an ex-substance user. And they say, I find the 12-step community to be in support of treatment in involuntary care. I find this frustrating because it doesn't follow the evidence, nor does it acknowledge the lack of supports for people when they leave treatment and how often they die when this happens. How can we bring the community of ex-substance users around to understanding these issues?
Lisa, do you want to go first?
I think there's for some reason, this responses to this crisis seem to be very polarized. So if you support prescribed alternatives or a non-prescriber model alternatives, then you don't support treatment. Or if you support treatment, then you don't support, harm reduction. And I think we have to be really careful that as many different people are using drugs in this province are the needs that we need to meet. We are talking about individuals, not a sort of homogeneous group. And so it has to come back to people as individuals. If this is a health crisis, then they have to have access to health professionals and places where they can go and patient-centered. I mean, that's the whole move in our healthcare system now, where it was, up till recently, and I don't know if that's shifted. Patient-centered. What do you need, patient? And firstly, it's respectful treatment. When you walk into an office or a hospital, you're going to be treated respectfully, no matter what your ailment is. And then we have evidence-based supports for you. 12-step programs can be effective for some people, but I've talked to many people who have been through programs that are sort of a 12-step model, and what it seems to come down to time and time again is, I was ready. It was the time where I wanted to make a change. Did the 12-step program facilitate it, or did it just happen to be there at the same time? I don't know. I don't, having reviewed thousands of deaths over the last several years, I don't see that as a meaningful one-off solution to this crisis. We need, I hate to overuse this phrase, all the tools in the toolbox, but it has to be patient-centered, and we have to be gathering evidence. And so I'm so grateful to you, Kasari, for raising your voice about this topic. And, with your profile, we need to be demanding of the province, okay, all of these things you're doing, What are the results? When are you going to report them? How many people are you detaining involuntarily? Where? What's happening to them when you release them? What are the outcomes 6 months later, 12 months later? We never, ever see that. We never see that data. And I can tell you, and then I'll stop. As Chief Coroner, we published extensive data on a monthly basis. And the people who are trying to respond in a meaningful way to the healthcare crisis, they valued that data because it gave them tools. We need more information, and we need to know what's effective and really what's not helping at all.
And if I may, Kasari, Lisa's comment there about the diversity. So again, remembering we're talking about human beings, individuals, communities, loved ones, sons, daughters, aunts, uncles, parents. We're talking about human beings, and sometimes that's the first thing to go. I think that kind of remembering that we really are talking about humans. But to Lisa's argument there, which was so central, is people with lived experience, whether it is of substance use dependence or mental health challenges or mental illness, they are some of the best architects of policy and practice shift, in my view. I think we've seen incredible changes brought about when we work collaboratively with people with direct experience in building out systems of care. And on an unrelated, but very related issue, I think about Circle, and so I mean this is something that we at CMHA have overseen and implemented in 7 communities across BC. Very much driven by people with lived experience of apprehension by police, lived experience of crisis in the mental health system. And so what we have now is a civilian crisis care response where lived experience is a feature of that response. And we've been able to take thousands of calls, and first responders like the police have only been needed in 2 to 3% of the time. So we're at 13,000 calls, batting a 97% rate, where this model, which is very much anchored in lived experience, is diverting from the need for those kinds of responses so they can focus on their core remit and what they need to do. And we're seeing really great examples of people being safe, life-saving, life-changing interventions. So I do think when it comes to this, finding ways to the question of bringing substance users around these issues, and inviting folks into design solutions, I think there's a lot of merit there. But to what Lisa said, these conversations can be so polarizing. They drive such polarizing and often quite angry responses. What really also needs to happen is dialogue and conversation. And that's why, like Lisa, I hold up my hands to you, Kasari, for holding a space gently and thoughtfully in the democracy that we live in, to have meaningful debate and conversation. We don't always have to agree, but let's connect to that common vision and purpose that lives are important. Saving lives is important. Doing all that we can to keep people alive so they can access treatment is important. If we can hold that through dialogue and conversation, I do think we will get further along than one size fits all solutions that are very intrusive into people's lives, like detention.
Thank you both for that. I want to switch gears slightly, although it certainly relates to so much of what we've been talking about. We've had some questions about human rights-based response, in kind of building on our statement, and which human rights are most at stake here. So I want to spend a moment talking about that, and then I'm going to turn it into a question for both of you. So there's a number of human rights issues here, and I'll keep it short for our purposes. But we've talked quite a bit today already about the lack of evidence supporting some of the policy solutions that have been prioritized here, and the evidence supporting other policy solutions that have been deprioritized. So voluntary care, involuntary care, safer supply versus criminalization, and so on. So if government takes actions that evidence doesn't support and could potentially contribute to deaths, contribute to serious bodily harm and brain injury, for example. We have a right to life and security of the person in this country. So undermining our rights to life and security of the person is a human rights violation. It's a constitutional violation. It's the issue, for example, that was used to support safe injection sites. With safe injection sites, when PHS, there's a case went up to the Supreme Court of Canada and said, this is the Insight program that has saved thousands of lives and reversed thousands of overdoses since it existed. It received an exemption from the federal government, so it wouldn't be prosecuted for allowing for harm reduction to happen in their spaces. And that was they almost lost it. They launched a challenge, and they said it's contrary to life, liberty, and security of the person, or life and security of the person in particular. The other issue here, though, is inequality analysis. So, Jonny, this is building a bit on what we talked about, what you mentioned in terms of the disproportionate impact on some communities. There is definitely a disproportionate impact on, for example, as you said, on construction workers. People are disproportionately male. And there's a very significant impact on Indigenous folks. And we've had a number of questions around that. I certainly want to say that that's an equality issue. That's a substantive equality issue. So where we see the disproportionate impact of certain policies, in this case, an undermining of people's liberty through involuntary detention, an undermining of their rights to life and security of the person through not implementing policies that the research supports, that disproportionately impacts Indigenous folks and other communities. So that's just a very quick encapsulation of a couple of the human rights issues that surround the toxic drug crisis. One of the questions that we received is, if substance use is truly a health issue, not a criminal one, what concrete policies and practices distinguish a genuine health-based, rights-respecting response from coercive care that simply repeats the harms of residential school and forced institutionalization of Indigenous people?
That's a very important question. Lisa, over to you first.
Thanks, Jonny. Well, I mean, obviously, drug use has to be decriminalized, because as long as we are treating people who use drugs as criminals, which potentially they're doing something that's illegal, then the focus continues to be on law enforcement, as it has been for so many decades. So decriminalizing isn't going to be a sort of a magic one that fixes everything overnight. And certainly we haven't seen that in this province, and nor was the expectation. But acknowledging that this is a health issue, and hopefully changing the whole tenor of the conversation, so that people who use drugs aren't, as I said before, so vilified and villainized. They are simply people challenged by a health challenge that I mean, there are people who use casually, and really their only health challenge is going to be if they run into a toxic batch of drugs, and that's going to take their life right away. Not everybody who uses drugs is drug dependent, but acknowledging that it's a health issue, and then having messaging and responses informed by the health community. Give this issue back to people like Jonny in mental health world, and the physicians and clinicians who can respond with evidence-based treatments. And to me, that is the only way that we are going to end this crisis, because as long as we are continuing to treat it as a crime and funding criminal law enforcement type responses, we have this really weird hybrid where government's funding treatment, and government's saying that treatment's important and saying that they're funding more beds, but at the same time detaining people for using substances. If they were doing something criminal, they'd be arrested, and so they're not subject to arrest for anything active that they're doing, and yet funding law enforcement on far too often direction. We're looking to law enforcement leaders to direction on this complex health issue. So personally, and having talked to so many people over the years, we have to clearly move this into the health arena, and then evidence-based health responses. And that's the only way that we're really going to get ahead of it. And it has to be a continuum. So from people who are substance dependent and could not survive a day without the drug they're dependent on, the provision of a safe alternative. But treatment for people who are looking for treatment, when, as Jonny said, the day they put their hand up, I want to get away from this. Here's where you go, and it's funded by the government. And then follow-ups, because oftentimes, I've seen people go through treatment. They're successful in terms of they complete their treatment. They are no longer using substances, and then they relapse 2 weeks later, or 2 months later, or 6 months later, and they die at home. And I've had families say to me, "We looked for counseling for him. We looked for supports. There's nothing available for follow-up treatment unless people pay for it. Not everybody has the money to do that. So it's going to need an investment, but we've been putting that investment in on the punitive side. We need to switch it to the health informed side. That would make a huge difference."
It's a great question, Kasari, and so much of it's been answered by Lisa's commentary there. I think of the work of Dr. Jamie Livingston, one of Canada's best known stigma researchers, and he's often talked about just how structurally embedded stigmatizing practices are within our system. And I don't think we're out of the woods yet in and around the criminalization of mental illness either. And so, substance use is criminalized. But if we just pause for a moment and think about, what is often the default response in communities across this country when someone's experiencing a mental illness or a crisis related to mental illness, it is often the police. And we see significant rates of what's often called trans-institutionalization, people with mental illness who have not received care and end up in other forms of institution too. Not because they've committed a crime, but jails, for example, those kinds of things. So, I do think really interrogating, what structurally needs to change in our systems of care. That's some heavy work ahead to get to the heart of the question around fundamentally seeing mental health related illnesses or substance use related illnesses in on parity, on an equal footing with physical health care. And some jurisdictions have legislated for this. I think of the UK. They have enshrined in their National Health Service an expectation that you won't be treated any differently by virtue of what you present within the health system. And there's good rigor around this is the range of treatments, and these are the choices you have, and we're going to take your consent rights seriously, and we're not going to let you deteriorate until you're absolutely in a crisis before we intervene in your lives. And there's challenges in these other jurisdictions, but I do think BC's in this unique position of some really good things underway, bumping up against some rapid shifts in policy in an economic crisis. And so those ingredients really do require a lot of intentionality around making sure we don't go back to the easy default here, which is mentally ill folks are violent, let's lock them up. Substance users, they're criminals too, let's lock them up. That's not where we should return to. And I think particularly recently on the mental illness side and its conflation with violence in media and political and public discourse, we are sliding. And I would say it's conversations like this that can hopefully enable us to put out our arms to stop that slide. And really remember, we're talking about human beings living with a range of complex and enduring chronic illness in lots of ways. And there's lots of structural things and medicines and therapies and things that can work if we deploy them all in earnest, where someone is choosing to access that care on their own terms.
We have 6 minutes left, and we actually, Lisa and Jonny, I'm not sure if you've kept an eye on this. We have had so many questions, such an incredibly engaged audience. So thank you so much to everyone who's shared your observations, your concerns, your experiences, and your questions. We're only just getting to some of them here, I'm afraid. I do want to, there's one theme that I just want to pull out here in the last couple of minutes with apologies to everyone whose questions we are not able to get to. There's a number around kind of strategy and advocacy? Like, where do we go from here? How do we make the changes that we've been talking about here? How do we push for the kind of data that you've talked about, Lisa? How do we, push for better care in a private setting? How do we ensure public dollars are spent in the way that we want them to be? One of the questions here is, how might we, as people in direct care, leadership, and other roles, effectively respond and counter the government's rhetoric involuntary care being substance use care being on the right side, and that it's about protecting kids, etc., as though a human rights based approach is not on the right side or about protecting? How do we effectively respond to that? And again, in this larger context of what's next, where do we go from here?
I really do think it's about finding ways to really hear from the diversity of people who engage with systems of care. We kind of see slices of perspective, right, when it comes to experiences of involuntary treatment, or the difference involuntary treatment could make in our lives. And what we want to avoid, that framing you put out earlier, Kasari, we don't want to out compassion each other, and we don't want to out evidence each other. They're actually evidence, like there are reasons to follow where most evidence lies. So maybe that's safe to do. We want to out evidence, and we want to follow the strongest evidence with these interventions. But I do think when it comes to stories, I don't think the broad diversity of human experience, of experiences of care, has ever been truly surfaced in this province. And so we just hear slices. We see the headline, we see the tragic outcome, the catastrophic loss. But we haven't had that kind of meaningful surfacing of the incredible diversity of experiences of people who've experienced involuntary treatment, hospital-based care, ERs, residential substance use treatment. Like, we haven't, as Lisa said so many times, so clearly, we haven't collected that qualitative evidence. We just hear the poll. The majority of British Columbians supported voluntary treatment. I think there's so much more to the story. And often that comes from lived experience. We convened a number of years ago, over 200 people who cared about the experience of people in suicidal crisis in the mental health system. And the stories that came forward from people who have lived experience of suicidality were profound. Their experiences that often felt more like containment and detention than actually treatment. I think we actually do a really good job of containing and detaining in the province. Maybe there is an opportunity. Well, there is an opportunity to do so much more in the area of treatment. I think the one glimmer of hope here on this piece is the Premier has committed to a Mental Health Act review. If anyone read the debates on the Mental Health Act amendments a few weeks ago, it was reinforced on the public record around the importance of that review. And that might be a space and an opportunity through a review that's independent and thoughtful and intentional, to really gather the perspective so that we can resist polarizing, we can resist binarizing, we can resist the kind of the anger, and find the way through this, because that's the only way, right, through this crisis, is to find a way through this in ways that change lives and save lives. So that would be my response to that very complex and thoughtful question, Kasari.
Thank you, Jonny. Lisa, final words on this?
Sorry, I have 3 screens in front of me in this office, and it's really throwing me. I think what I'm seeing so often now is compassion being really challenged. People are economically challenged. They see people living in the streets in their communities. They see people living with mental health challenges in their communities and substance use challenges in their communities, and they just want it to go away. And that often involves they're running out of compassion, and they're angry. There's a certain anger towards those who want to respond with compassion and kindness, and the do-gooders, or I see letters to the editor in my paper. I think we have to put kindness first. I think we can't not lose sight of that. And if we as community members are uncomfortable with seeing the people lounging in the doorways on the streets or sitting on the street corners, nodding off, then we have to advocate to our elected officials, starting with the mayors, up to our MLAs, up to the premier's office. Where are the places for people to go, particularly as winter sets in? In Victoria, people are moved from place to place, 7 a.m. Tents got to go, or they throw them out. What do we have available for people that they can go to during the day, provide the support? So, I mean, I know this sounds really kind of wishy-washy maybe, but that's where it starts, recognizing our fellow human beings and doing what we can to help them. And this notion that somehow we'll just sweep them off the street and put them somewhere, problem solved, that's not going to solve any of the problems. You might do that with this batch of very vulnerable people, but I can tell you that there's another group of very vulnerable people coming down the road because we haven't addressed the upstream challenges. So really advocating for compassionate, kind responses and direct action by writing your mayor, your MLA, and your premier. They do listen. They really do care about your opinion.
And Kasari, I know we're ending, but Lisa's comments remind me of a really powerful quote by DJ Larkin that they made recently. We all need to put our bodies somewhere. Like, our bodies exist, and we have to put our body somewhere. And if I don't have a home to put my body in, or if I don't have a washroom to use and to put my body in, my body has to go somewhere. And I just thought that was such a powerful remembering that we take up space with our bodies, and if there aren't safe spaces for our bodies, for us to put our bodies, that can be really important. So that's why I worry around a trend to remove from sight. So the state removing bodies from public view and putting them into, more kind of carceral or institutional settings. But the fact is, we do have to put our bodies somewhere, and until we have ready access to housing and those kinds of things, some folks' bodies will be on the street, right? Because that's the only place to put them. So, yeah.
What a powerful way to end. Thank you so much for both of you. Our bodies take up space, and so do our voices. And that's what we've tried to do here. I know we've been joined by a lot of folks working in this field who are raising their voices. We hope this was helpful to you. If you want to share this conversation later, will be recorded. It is recorded, and it will be posted on our website. We do have the resources that have been posted in this chat are also on our website. The Guy video that we showed earlier, the position statement that our office put out. Of course, Lisa's many reports are available on the coroner's website. Jonny's, the work of CMHA is available there. We urge you to go and look at those resources if you would like information. Feel free to email us at info@bchumanrights.ca. We know there were a lot of questions and comments that we didn't get to. Thank you again so much for your engaged interest, and wishing you all the best.
Thanks, everybody.
Thanks, everyone.
Lisa. Thank
Take
you,
care.
Jonny. Thank you, John and Lisa.